Hi everyone, I'm Dr. Roman and I'm a board certified hematologist oncologist, and let's go over some common IPMN questions. I get asked questions all the time on this topic, so hopefully I'm able to help you out and answer some of these questions that you may have. Now remember, I'm not your doctor, guys. I'm just here for educational purposes. I'm not here to give you advice. I recommend that you read my medical disclaimer. Education, that's all I want to do, and hopefully I am able to help you out and maybe answer some of these questions. And when you go talk to your doctor, maybe you can have a more fulfilling, more educational conversation with them because you know a little more when you speak to them. That's my goal here, not to give you advice. So before I get started, I urge everyone, if you have not seen my IPMN and pancreatic cyst video, I recommend you see that video first because we cover a lot of material there. That video is over an hour and I believe 12 minutes long, and we really discuss a lot of information there. So this is sort of a supplement to that, okay? So with that being said, let's get started. So question number one, and these are questions that patients have actually asked me. I have people calling my office. I have private, people sending me messages through private message or through my YouTube channel in my comment section. And guys, I do practice. I'm seeing patients, so it's hard for me to get, to be able to answer all your questions. But that's the reason I'm here right now, okay? So remember, seek your doctor for advice. I don't know the details of your specific case, okay? With that being said, question number one is, what do they mean by a field defect in a patient with an IPMN? Simple. IPMNs, when you have one IPMN and you have an actual IPMN, you're at risk for developing an IPMN anywhere in your pancreas. And they believe that you have a defect on your entire pancreas that predisposes you to developing an IPMN. So if you develop an IPMN in the tail, you can develop one in the head of the pancreas. And that's why it's important that if you go to surgery, as an example, if you have a distal pancreatectomy or half your pancreas is removed, your body in the tail, because you had an IPMN in the tail, you need to continue to be monitored because you can at a later time develop another IPMN at another site in your pancreas. That's why they believe it's a field defect and you're at risk of developing IPMNs anywhere in your pancreas. All right, hopefully that answers that. Number two, the location of the IPMN and cancer risk. Okay, so we know that the type of IPMN you have, for example, a mixed and a main duct IPMN has a much higher cancer risk than a branch duct. But the questions that I'm asked, mainly for branch duct, is if I have a branch duct in the head of the pancreas versus the tail of the pancreas or the body, does one have a higher risk over the other? And the answer is no. The only difference is if it's in the head and you need surgery, you're going to need a Whipple. Whereas if it's in the body or the tail, chances are you'll need a distal pancreatectomy. But the cancer risk tends to be the same as long as it's the same type. For example, branch duct, they all carry the same risk. And of course, you have to look for the high risk features, the intermediate risk features, which we're going to go over later on. But if you have an IPMN in the head, because that's usually where the question comes in, no, it does not mean that your IPMN in the head has a greater risk than the IPMN in the tail, okay? What about if you have multiple IPMNs versus one IPMN? Of course, the more IPMNs you have, the higher your stress level. And most patients with an IPMN do not have one IPMN. Most people in due time will develop multiple IPMNs because remember, it's a field defect. But it's actually more important that you assess each cyst individually than to be worrying about having multiple cysts. Okay, so in general, no. Your risk of cancer, for the most part, probably does not go up if you have multiple cysts. Because you can have multiple small cysts or have one large cyst with nodules and wall enhancement. That's a much riskier, much higher cancer risk patient than the one with multiple IPMNs. I've seen patients that have a pancreas full of IPMNs and they're all super small, less than 1 centimeter. And that patient, for the most part, is low risk. Now remember, again, as long as it's branch duct. Now, also remember that you have to take other factors into consideration because we know that there are patients that have an IPMN and can develop pancreatic cancer at another site of the pancreas. Okay, so just because your IPMN is in the body does not mean you can't get pancreatic cancer in the head. You can still develop a pancreatic cancer because we are all at risk for pancreatic cancer, even people without an IPMN. Okay, so nowadays it's about what, pancreas cancer is the fourth leading cause of cancer death in the United States. So it's more common than we think. And I actually see a lot of patients with it, so unfortunately. All right, so what about your CEA in the fluid? So you have an endoscopic ultrasound, they do an FNA, and they draw a CEA level. You know, because you saw my video, that if your CEA is greater than 192, it implies that this is most likely a mucinous lesion. That's it. Now, the question that I've been asked is, if you have a very high CEA in that pancreatic cyst fluid, does that mean you have a higher risk of cancer? And in general, from what we know, the answer is no. So a very high CEA just means that this is more likely a mucinous lesion, period. And also, we do not use the CEA level in your pancreatic cyst fluid. I want to make sure you're not confusing it with the blood CEA. I'm talking about an FNA CEA. We do not use the CEA to decide if the patient should go to surgery or not. We do not use the CEA to decide surgery. What about another question? Cytology. If I have a negative cytology, am I good? Do I maybe not have an IPMN? Guys, cytology is not a great test. 50 to 60% of the times, cytology is negative. For those of you who do not know, a cytology, you have an endoscopic ultrasound, they do an FNA, they draw out some fluid, they take that little fluid, they spin it, and then the sediment tends to go to the bottom. They take that sediment out and they look at it under a microscope. And what they're looking for are atypical cells or cancer cells. So 50 to 60% of the times, even with cancer, okay, it can be negative. So it's not 100%. Number two is that a lot of times you'll find debris. A lot of times you'll find lymphocytes or white cells or particles or whatever. I've seen all types of descriptions. And that usually does not mean anything. You're really looking for atypia or atypical cells, or of course, malignant cells. If you see that, then you have to act upon that. But I guess the teaching point, the way that I want to answer the question is, just because your cytology is negative does not mean you're out of the woods, that you have nothing to worry about. No, of course. If it comes back negative, that's great, of course. But I just want to make sure, because I've seen some patients get lost to follow-up because they were told cytology is negative and they think, perfect, I'm done. No, you need to continue being followed up. What's the most common location of all IPMNs? Well, the most common location is in the head of the pancreas. But that really doesn't matter because, for example, mine are in the body. So everybody's different. It's just the head does tend to be the more common. What are the risk factors for IPMN? And this is a hard question to answer because none of these have been fully or convincingly proven to cause an IPMN. And they are age, smoking, diabetes, and alcohol. Well, age we know is definitely a risk factor. Why? Because the older you are, the higher your risk of finding or developing an IPMN. Most people with IPMN are in their 60s or 70s. But I'm 49 and I have 2 of them. So there goes that. Smoking. We know smoking is associated with pancreatic cancer, but we cannot conclusively say that smoking causes IPMNs. If you look it up, it's one of the risk factors, but I think that's more because it's a risk factor for you developing malignancy, not necessarily causing an IPMN. Same with diabetes. Is it that the IPMN is causing diabetes, or did the diabetes cause the IPMN? Guys, hasn't been proven. I'm not a diabetic. I know multiple people with IPMNs. They're not diabetics. Some of them are, but a lot of them are not. So there goes that. Alcohol. It's also, again, alcohol is known to increase the risk of pancreatic cancer. Now, has alcohol been conclusively proven to cause IPMNs? The answer is no, but we know alcohol can increase your risk of pancreas cancer, so knock it off. Now, a little drink now and then is probably not going to do anything. Me, to be honest with you, I cut it out cold turkey. I don't need alcohol to live, but, do I think a little drink from time to time? No. And a strong family history of pancreas cancer, we have seen a higher frequency or incidence of IPMNs in patients who have a strong family history of pancreatic cancer. That's just something that we've seen. So there goes that. Diet. Another question. Will my diet influence or worsen my IPMNs, or will it improve my IPMNs? Guys, nothing as far as diet is concerned has been proven to make your IPMNs better or worse. Period. I've said this to patients and they'll come back and they'll ask me the same question. Well, what about pizza? Well, what? Guys, nothing has been conclusively proven to make an IPMN better or worse. Now, what did I do? Of course, I cleaned up my act. I stopped the fast food. I stopped eating the chips. And every once in a while, I'll have something. But for the most part, I really cleaned up my act. Because do I think diet is going to help? I don't know. But is it going to hurt it? I'll dare to say definitely not. So that's that question. What about exercise? Again, not been proven to make it better or make it worse. Now, do I think that living a healthy lifestyle, eating healthy, and exercising is a bad thing? Absolutely not. Exercise has been proven to reduce the incidence of other types of cancer. So again, it would make sense that it's not going to hurt me with an IPMN. So I would say yes, exercise. Another question, what about the diabetes medications like Ozempic, Rybelsus, Trulicity, Victoza, Mounjaro, all these weight loss diabetes medications? That's the new fad that, they could possibly cause pancreatitis. The answer is we do not know. We do not have data. We know that some of these can cause pancreatitis, although it's rare, but will they make your IPMN worse? We do not know. I know multiple people who are taking these and they're doing great. They're losing weight. They tell me that their diabetes is under control. So they tend to be pretty good medications. Me personally, if you ask me, I would probably avoid it. But do I have data to prove to you that you should not be on one of these medications? The answer is no. So ask your physician. I can tell you that they cannot say it does and they cannot say it does not, because nothing has been proven. Now, I can tell you that pancreatitis is a possibility, but I can also tell you that it is rare. These medications can cause pancreatitis, but it is definitely not common. I actually know a lot of people on them, and for the most part, most of them are doing very well. All right, symptoms. Another very common question. The symptoms that I'm having, are they caused from the IPMN? And guys, for the most part, most patients with an IPMN are asymptomatic. The vast majority of patients with an IPMN do not have symptoms from their IPMN. But if they do, the most common symptoms tend to be nausea, vomiting, abdominal pain, and weight loss. But then again, those are very common symptoms. So how can we attribute them to your IPMN or not? And I'll give you some tips or pointers. Again, discuss it with your doctor. I'm just here to educate. But the first thing I would do is exclude pancreatitis. Now remember, there's two types of pancreatitis, acute and chronic. For the acute, you want to check an amylase and a lipase and make sure that you're not having pancreatitis, because we know pancreatitis can cause abdominal pain. Do you have chronic pancreatitis? Chronic pancreatitis is much more difficult to diagnose. If you have an MRI or a CT scan, unless you have very advanced pancreatitis, you can miss a chronic pancreatitis on a CT scan or an MRI. And I found that the best test to make this diagnosis or exclude a chronic pancreatitis is an endoscopic ultrasound. So exclude pancreatitis. Make sure your common bile duct is normal. Make sure your gallbladder is normal. You want to make sure you don't have an infection, what they call a cholangitis, a cholecystitis, or you don't have a stone causing blockade, or maybe a stone in your gallbladder that's causing pain. That's a common cause for pain, especially after you have a fatty meal. So make sure your gallbladder and your bile ducts are okay. They're not dilated, no stones, etc. Make sure your liver enzymes are normal. Make sure your what they call your AST, your ALT, that you're not, you don't have a hepatitis. Make sure that your alkaline phosphatase is normal. Make sure that your bilirubin is normal. So also something you have to look at. The other thing is make sure that your main pancreatic duct is normal in caliber. Because if all of these are negative, meaning you have no pancreatitis, your common bile duct and your gallbladder are normal caliber, no stones, Your main pancreatic duct is completely normal. It's nice and thin. There's no, I mean, all of this is negative. I would dare to say that most likely your symptoms are not due to your IPMN. But again, you have to talk to your doctor about this. The next question are tumor markers. Besides the IPMN themselves, tumor markers is probably the next highest reason for stress in patients with IPMNs. And the tumor markers, now we're talking about tumor markers in the blood, not the FNA, which we mentioned earlier. So tumor markers, mainly your CEA and your CA19-9. So I just want to tell you this. If you have not seen, I have a video in my channel about tumor markers. It's very brief, it's very simple, but you can check it out if you want to. So let's first talk about the CEA. CEA, which stands for carcinoembryonic antigen, is a very nonspecific tumor marker. It's found in adenocarcinomas, which can develop anywhere in the body. The colon, the breast, the prostate, the lungs, the stomach. I mean, multiple places. So just, having a very high CEA may imply having a cancer in any one of these sites, not necessarily the pancreas. Number 2, cigarette smoking can elevate your CEA. Usually not that high, 5, 6, I've seen it 7, 8. So, just keep that in mind. Also, I have seen CEA levels greater than 40, very high, and I've never found cancer in the patient. I've seen multiple patients with CEAs between 5 and 10, never been able to find cancer. And it causes a lot of stress. I'm not talking about IPMN patients. I'm talking about everybody. And they're thinking, oh my God, I have cancer, and I'm not able to find cancer anywhere. But of course, if it's high, you gotta be worked up. CA19-9, the same thing. CA19-9 is usually pancreas, biliary tree, gallbladder. So any infection, a stone, pancreatitis, any one of these things can elevate your CA19-9. But of course, so can a cholangiocarcinoma or a cancer in your biliary tree or a pancreatic cancer. So it causes a lot of stress. Now, I do want to tell you this. I actually had a patient with a CA19-9 extremely high. And when I say extremely high, I mean extremely high. I don't want to mention numbers, but have not been able to find cancer in this person for years now. I also have multiple patients. Normal CA19-9 in most labs is about 37. Multiple patients, 45, 50, 40, and been following them for a very long time. It causes a lot of stress. It makes me anxious. I'm looking at the biliary tree, the pancreas. A year goes by, 2 years go by, 3 years go by, can't find cancer. So obviously it's not due to cancer. Yes, you got to get worked up, but a positive or a high result, positive meaning high, is not necessarily a diagnosis of cancer. That's the take-home message here. So, definitely causes a lot of stress, Sometimes I actually ask myself if it's even worth doing, because I've seen so many people get so stressed out, and rightfully so, rightfully so. But all right, now let's talk about high-risk features. So if you have, and before I say this, guys, remember, there's a lot of classifications, there's a lot of recommendations out there, there's a lot of associations, whatever you want to call it, Japanese, you have your Europeans, your American literature, and everybody tends to have their own guideline, if you will, or guidelines. What I tried to do is I tried to clump them all together and just give you a straightforward, common sense approach to this. And what I would consider, or most consider, high risk feature, or what they call high risk stigmata, are an IPMN causing jaundice. So if you have a large enough IPMN in the head of your pancreas to make you yellow or your bilirubin to be high, that's high risk. If you have an enhancing nodule greater than 5 millimeters or greater, that's another high risk. Or if you have a main pancreatic duct greater than or equal to 10 millimeters, that's another high risk. And if you have any one of these, you should strongly consider surgery if you're medically fit to tolerate that surgery. Again, and that's a discussion between you and your doctor. What about moderate risk, what they call worrisome features? These are less important, but they're important to know and to look for. And those include a cyst greater than 3 centimeters, thick or enhancing cyst walls, a main pancreatic duct between 5 and 9 millimeters, a non-enhancing mural nodule, changes in the main pancreatic duct caliber with distal atrophy. So, you see that there's changes in that main pancreatic duct caliber, history or present pancreatitis, lymphadenopathy that you see around the lymph node, you see around the pancreas, you see large lymph nodes around the pancreas. You need to get that worked up. A high CA19-9, cyst growth greater than or equal to 5 millimeters every 2 years. I've seen people, oh, my cyst grew by 1 millimeter, by 2 millimeters. Guys, these are tiny changes. That could just be the radiologist reading the film. Okay, you're talking about a millimeter. That's so tiny that when they're reading the film and they're taking that measurement, the mouse can simply it can make that little miscalculation by 1 to 2 millimeters, very small. But if you have greater than a 5 millimeter change in 2 years, it just puts it a little higher risk, as well as if you find intraductal mucin. So that's when they do the endoscopy in the sphincter of Oddi, which is the sphincter where the common bile duct and the main pancreatic duct join to release all its contents into your small intestines. If you see mucin pouring out during an endoscopy, if they find mucin pouring out of that, then it definitely puts you at a higher risk. That's usually because when you see that, it's usually associated with a main duct IPMN. So now, if you find any of these intermediate risk, then you should strongly consider an endoscopic ultrasound if you have not done so. In most recommendations, that's the Japanese, European, the American, that's what they tend to recommend, is that if you find any of these on MRI or MRCP or a CT scan, to consider an endoscopic ultrasound. And then based on what they find there in the discussion with your doctor, then you'll decide, are they going to continue to observe, or are you going to go to surgery? And it's a tough decision to make. It's not easy. Now, we do know that if you have 4 or more of these that I just mentioned, 4 or more, then your chances of having an underlying malignancy or high-grade dysplasia is much higher. That just makes sense. The more of these you have, the higher risk you are. All right? What about, okay, my IPMN is less than 1 centimeter. Should I worry? Well, should you worry? Yes, in the sense that you need to continue to follow up. But overall, if you have a branch duct IPMN and it is less than 1 centimeter and you have no high risk features or intermediate risk features, the chances of you having an underlying cancer or high grade dysplasia is exceedingly small, very rare. So most people recommend that if your cyst is less than 1 centimeter and there's no intermediate or high risk features, most would recommend against an FNA. It's not worth sticking a needle in there for the most part. All right, so that's good news for those of you who have a very small cyst. Now, if your cyst is a little larger than this, then that's where you have to start looking and taking other things into consideration. All right, so what are the risks of an FNA? Why not do an FNA? Well, because an FNA carries a risk of 4 things: infection, bleeding, pancreatitis, and something that we call seeding. And I'll explain that. So first of all of these are very rare. Remember that your pancreas does have a lot of blood vessels. Your pancreas produces digestive enzymes. So if you poke your pancreas, you could bleed. Those digestive enzymes could cause pancreatitis. Also, since the FNA goes through the stomach wall into the pancreas, you could introduce a bacteria and develop an infection. These are things that can happen. Extremely rare. Okay, extremely rare. Seeding, okay? What seeding means is if you have a cancer in the pancreas and you put a needle in there, and when they pull it out, they think theoretically there's a small risk that you can spread some of these cancer cells. And that's what they call seeding. Now, according to the literature, it is extremely rare for this to happen. And some literature states that it's probably non-existent. So I would say, I like to, think worst case scenario. It's extremely rare for that to happen, but I guess it's theoretically possible. All right. The next question, and we're almost done. We're almost done, but I think we've covered a lot of material here. What is the best imaging test? And I'll tell you what, there is no best imaging test. Every test has its pros and its cons, but in general, I will tell you this. CT scan without contrast, not a very good test in my opinion. CT scan with IV contrast, it's a decent test. Now I've seen CT scans even with contrast miss IPMNs. An MRI with contrast is a very good test. An MRCP without contrast, which most MRCPs are without contrast, is a very decent test. But if you do an MRCP with MRI with contrast, it's a much better test because you can see a lot. You can see cyst wall enhancement. You can see if nodules are enhancing. In other words, anytime you do an MRI with contrast or a CT scan with contrast, it's going to provide a better image, period. The bad thing or the downside is that these contrasts have risks. And if you have not seen my video comparing CT or talking about CT scans and MRIs that I have in my channel, I recommend you do so because these are things that you need to know. For example, I'm 49. When I've had imaging tests, I've had MRCPs without contrast. I do know that if I have it with contrast, it's a better test. But you know what? At 49, I'm going to have an MRI every year and I'm going to have one with contrast. I made a decision to avoid contrast for myself because I feel that if I have that contrast every year after 5-10 years, what's going to happen? I mean, is that going to lead to other things? So I decided to do it without contrast. But everybody's different. This is a conversation between you and your doctor. And I personally think that the best test is an endoscopic ultrasound. In my opinion, that's the best test. Now, this is operator dependent. If the person doing the endoscopy and the endoscopic ultrasound does not know what they're doing or they don't have a lot of experience, they can easily miss a cyst. But then again, if you have an MRI, it's also dependent on the radiologist reading the film. If the radiologist is not paying attention, they may miss it. So I've seen everything. I've seen MRIs find the cyst that an endoscopic ultrasound did not. I've seen endoscopic ultrasounds find the cyst that the MRI did not. But what I've seen the most is a CT scan without contrast missing a cyst that was seen on MRI even without contrast and also seen on an endoscopic ultrasound. So my personal opinion, endoscopic ultrasound number 1, MRI or MRCP with contrast number 2, an MRI or an MRCP without contrast as number 3, and a CT scan with IV contrast as number 4, and a CT scan without contrast as bottom number 5 shouldn't even be done. So, again, that's my opinion. You can have this discussion with your doctor. PET scans. So, guys, PET scans are not good to follow IPMNs. PET scans are used to find cancer, to look for cancer. If a PET scan is lighting up in your pancreas, then yes, you might have cancer. Remember, PET scans light up in infection, inflammation, or cancer. I've also seen patients that I know have cancer and their PET scan is negative, so it's not 100%. So we do use PET scans. I do use it sometimes mainly to look for cancer or to follow a cancer patient, but to follow an IPMN to look for high risk or intermediate risk features, I do not recommend a PET scan. Plus, a PET scan has still a small amount of radiation, but a little more than your typical CAT scan. All right. Now, the last thing that I want to mention is, as I mentioned before, guys, if I mention something that is different than what your doctor said, don't panic. Stick to whatever your doctor told you because remember, your doctor knows the details of your case. The other thing that I want to tell you is, as I mentioned before, there are multiple guidelines. So maybe your doctor is using one guideline in specific. I kind of clumped everything up together. Okay, I like to approach these things from a common sense standpoint, if you will. So I have my own way as a physician to do things. Your doctor may have their way of doing things, and it doesn't mean that they're correct or I'm correct. It's just different ways. At the end of the day, what we want to do is try to prevent these things from becoming cancer. And let's face it, and again, remember, I have IPMNs too. The worrisome thing here is that if you do not detect this on time, if you develop the pancreatic cancer, then statistically speaking, that's not good. So the whole goal here is to try to find it before it becomes cancer or before it spreads, especially. So that's why my approach is to be a little more aggressive. As far as another question which I get asked is when to image, and it really depends. Every guideline is different. For example, if you have less than a 1 centimeter lesion with no high-risk features, some people recommend every 2 years. Some people recommend yearly. If you have bigger lesions, for example, greater than 3 centimeters, and they opted to follow and not go to surgery, then some guidelines recommend repeating it every 6 months to 1 year. Different guidelines have their own different recommendations, but I dare to say that less than a 1 centimeter IPMN with no intermediate high-risk features, every 1 to 2 years. If you're greater than 3 centimeters, every 6 months to every year, as long as you don't have other high-risk features. And if you're somewhere in between greater than 1 to say less than 3 centimeters, and you're somewhere in between. Me, for example, what I chose to do in my case is I'm having an MRCP without contrast every 6 months for the first 2 to 3 years. That's what I chose to do. I already had an endoscopic ultrasound. I confirmed everything. I made sure there was no high-risk features on there. And then, if I do the MRCP and anything changes, then I probably will go to an endoscopic ultrasound. That's the way that I chose to do it. For those of you who want to know, my IPMN when it was first diagnosed was, one of them was 5 millimeters. The other one was 1.3 centimeters. No high-risk features. On my follow-up MRI, 6 months later, or MRCP better said, the 5 millimeters was still 5 millimeters, and the other one went from 1.3 to 1.1. So I was happy. It shrunk a little bit, but again, it's within that, machine difference or radiology reading difference. One radiologist can say, again, 1 millimeter, 2 millimeters is such a small difference that it's an insignificant change. So I'm due for my next MRCP in a couple of months. So we'll see what that shows. So that's it. I really do hope this helps you out. Remember, I'm not your doctor. I'm not here to give you advice. Please, please, please stick to what your doctor says. Sometimes, I've had some people have gotten upset because I've said certain things. Guys, I'm not here to hurt you. I'm here to help you out. So I really do hope that this helps you out. Guys, subscribe to my channel. It shows me that you're getting a benefit. Like the videos. It also moves it up on the algorithm so other people with IPMNs can find them. Okay? So catch you on the next video.